Owen, thank you for joining the Health Tech Nerds crew here Friday afternoon. I'm excited to chat with you about some news that came out this week on Included. It spurred some conversation in community talking about what y'all are up to in terms of alternative plan designs. So, welcome the opportunity to learn from you. I thought it'd be fun to start off conversation, just level setting on current state of Included's product offering. Obviously it's been you started as Grand Rounds, became Grand Rounds plus Doctor on Demand, became Included in the navigation space holistically. Now adding on this plan design, could you level set on like what Included is today, what's in the suite of product offering, and where the plan fits into that?
Absolutely. Yeah, in this may be a terrible analogy, but it feels like we have this master plan for this incredible sort of you know, iconic, strong, powerful house. But instead of sort of like building each of the rooms connected perfectly in sequence, we're adding on an addition that may feel like it's 10 or 12 feet away, but then you're like, oh no, I see it. I see the master plan and how these things are coming together. And at some point when I have more time and I have the writing skills that you have, there's a blog post that's been cooking for me where I want to sort of revisit a blueprint that I wrote up in 2014, which basically talked about trying to get to this very moment, actually a little bit beyond where we are, but we can get into that. So your question is, take me through the product suite. So Grand Rounds started as a specialty care and navigation focused company. We started to do our own telemedicine. Instead of trying to recreate that wheel, we went out and we acquired what we thought and now know would be the absolute best franchise in the business that would give us urgent care for sure. So your classic telehealth 1.0 sort of stuff, but also a really underappreciated and fully employed and robust behavioral health practice. I think really get all sort of range of behavioral health, but particularly underappreciated is the depth and the quality and the availability of our psychiatry practice. And then also inside of the Doctor on Demand portfolio, and the thing that you're going to hear me revisit time and time again in our conversation today was primary care, but not just primary care that sort of had the features of telehealth, but primary care that was actually designed to be accountable, primary care that was designed to be longitudinal, primary care that once again had a fully employed staff model. That's a really key hallmark of how we've thought about that business. We bought Included Health, which the original Included Health, which your community knows. Many people out there now just know the whole thing is Included Health and just sort of lost track of the site that there was a much smaller company that was started by a bunch of Minnesotans actually, and Colin Quinn as well. And that business taught us how to talk to underserved communities and engage beyond traditional benefits channels, and that's sort of grown like wildfire inside of our collective company. Which brings us to today. So now we have this care portfolio I talked about. We have navigation that was really built to be accessible, personalized, fast, built on that quality stack that Grand Rounds had sort of so lovingly honed through machine learning and AI for so many years and wanted to bring to more people through navigation. We put all of that together, and that sets us up to think about true plan alternatives. And, anybody who's sort of been following this construction that I was describing to you, Kevin, knew that this is where we were going to have to go. That in order to bring, all of the clinical intensity, all of the focus on personalization and access, all of our work and quality, to bring that all together for, both clients and members, that we were going to do it in the form of a plan. So long answer, but that's really where this came from historically and where we stand today on the whole portfolio.
Yeah. I'd be curious. I've got my own narrative in my head of where the employer market's gone over the last few years. Obviously, everybody's seen the cost increases that employers across the spectrum of size are dealing with these days. And I can imagine that, there's been a wave of adoption of navigation solutions over the last several years, yet employers are still dealing with these cost increases. So to leverage the full extent of an offering like yours, go upstream and own the plan with those employers. But I'd be curious, why now from a go-to-market perspective? How do you think about kind of state of the market of conversation with those employers, and what's their journey been over the last few years of thinking about the navigation product and you guys expanding the offering to now kind of the I don't know, full stack, if you will, but the plan.
Yeah, there's a lot in your question. So I'm going to start, but I'm hoping you'll walk me through it because I want to get
Yep.
a lot of pieces here. But to start, the very plain reality, it's a depressing one, but it's plain, nobody has to guess at it, is that for the decade plus that I've been building this company, we all complained about costs because we didn't like that costs were going up 6, 7% a year and that we didn't feel like we were getting commensurate improvements in outcomes. That felt sort of problematic to people. Now it feels existential for employers because at 10, 11, 12, 13%, which is the first we've seen that post Affordable Care Act,
Yep.
you actually start to sort out real questions on whether businesses can continue to afford benefits the way that they have. And that creates a whole snowball effect on the problems that you could expect. So I think the urgency around cost is now at the forefront. One of the things that we have learned how to do really well at our company, and it was not an overnight thing by any stretch of the imagination, is to both estimate where cost savings are going to go in a population and then design the clinical programs and engagement programs to actually deliver through those costs. But even when you know how to do that, it takes years to actually figure out whether you're actually doing it and delivering it. I mean, I think some of our first cohort data that was reliable only arrived like 5 or 6 years after I started the company. So that was just something that we needed to sort of wait and build on. The other thing that I think is happening, which is part of your go-to-market question, is employers are hip to the fact that their classic sort of carrier managed care company, um, is doing a little bit of a shell game on the costs associated with pharmacy and medical. And what I mean by that is since all of the large managed care companies own their own PBMs, and they know that that's where the game is, both today and into the
Mhm.
future, setting aside sort of all the political questions there, they are very eager to sort of retain that commercial business, even if the medical product is not particularly sort of discerning on quality of the underlying network and the clinical decision making that goes into compiling that network and directing people on that network. So in the market that we serve, which are the ASOs, we've seen an openness to these alternative plans. And I expect you to ask me, so I'll just sort of tease it right now that the two best known alternative plans, at least so far, are also owned by those same carriers. And I actually think that they've been, in many ways, wonderful products, but they just reinforce that same sort of challenging loop that I was just describing. So my very strong sense is, and we'll see if the market bears it out, that everybody's ready for an alternative that's not owned by the traditional players.
Yep. Yeah, it's been interesting to watch. As you know, I follow along on earnings calls, and you
Yeah.
noted for the past several years now has been talking about Surest for forever as
Yeah. And they
fastest
should.
growing
I mean,
product driving
it's
the
done
market.
great.
Yep. Yep. I'd be curious how do you break down the market these days in terms of employer clients and where are you seeing the most interest? Obviously, we see small group, huge spike increases to the point where carriers are backing out of the market. They're moving into ICHRA, exchange-like plans, etc. Um, where do you see, like, where are you guys going to market with these alternative plan designs?
Yeah. Well, you know that we have, incredible sort of reputation and share in the, 10,000 and up group range. I think that's been where we've just really worked our tails off to be, reliable, accountable partners for the companies that sit in that bracket. So you should expect, and in fact, of the lives we already have on the platform, they are coming from that segment of the market, the 10,000 and up. But interestingly, I actually think that this is going to be our fastest growing product in the below 10,000 market. So whereas we had options for that market always, and we have a number of clients that sit there, they always sort of required a little bit of integration, implementation that was out of the standards for how those companies actually bought products. They were very used to buying a medical plan, probably used to buying a benefits administration service. Beyond that, they looked to their carrier or whoever to bring in point solutions, to bring in high value options. Here, I think we can start to talk about either whole population or slice business to that market. It's all obviously a super exciting place for brokers and consultants to play too, for a whole bunch of dynamics we can get into. So I think it's going to perform incredibly well in that part of the market,
Yeah.
probably all the way down to, call it 500 people.
And can I ask, so you said either slice or full replacement. If I'm an employee at, 10,000 plus life group, Coca-Cola, uh, to pick a random large company, and I'm signing up for benefits and open enrollment, am I signing up for included whatever health plan to, like, am I signing up for an included health plan, or like what's the brand I'm signing up for, and where does included fit now when a large group is offering your plan?
Yeah. So maybe I'll just give you some real stats because I think it
Yep.
wasn't totally clear from the announcement we made that we're already doing this. This isn't sort of like some conceptual forward thing. So we offered it to 125,000 covered lives, potential covered lives across 8 states, and we had just over 20,000 enroll, which we thought was incredible for year one of a product design.
Yeah.
It tends to be the most expensive product design too. We can get in the reasons for that. And so very, very delighted to see that uptake in that slice. Um, what we expect to be doing here is seeing it sit alongside some other options for now. We would love to and could fully technically support being a whole takeover for a business. And I suspect we'll get there. I suspect we'll be pushed by our market faster than we're pushing the market. But
Yeah.
for now, I think that like burn-in period to have people understand what this actually is and how it works, I think it's going to be offered on Slice. It doesn't, unlike those other plan designs, we were talking about Surest for a second, Coop would be in this category too. It doesn't require like a new learning on how the fundamentals of the health plan works. We sort of take care of that. We'll get into hopefully the experience side of this in a second. Um, so we're really pleased with the uptake rate so far. We think, in its inaugural year that exceeded our expectations, and we're gonna ramp that up a ton next year.
Yeah, that's impressive. I when you say it doesn't require any learning on the fundamentals, do you mean for the employer in terms of what they're offering, or the employee in terms of how they
Both,
are utilizing the
both.
benefit?
Both.
Yeah,
You sort of, you think about the alternative plan, just using Surest again. The sort of clever idea behind Surest, and I think it's a very nice implementation. I haven't looked at it in a couple of years, so I could be sort of may have advanced in different ways that I don't appreciate. But the the context was like, you buy the insurance you need, which sounds lovely, but in practice, it's not a very clinically intensive product as I understand it and as I experienced it. And because of that, you're making decisions based on your coverage that may not actually feel fully guided with respect to what you actually need. So here, what we're trying to say is like, we're not going to play games on the amount of coverage you have out of the gate. You're going to have the full bet. The underlying plan is a PPO.
yeah.
You're going to have the full benefit of that PPO, but instead of sort of trying to, play the sort of consumer part of it on the unit costs, we're just going to lean more heavily into a much more guided experience based on primary care that allows you to sort of pick and choose and build a dynamic care plan for every participant based on their goals for the year. And again, because of all that data that we now have, we sort of feel confident in the actuarial experience to say this is going to deliver the outcomes that we need against a certain population spec.
And so is it gated to a virtual primary care doc inside of included, or like mechanistically,
Yeah,
I'm one of the 20,000 folks who signed up for it. Like how do I start the experience? And then how do you
great.
influence care?
Okay, well let's talk through that because that part
Yeah.
is super important. But let me actually answer the other question you asked like right before that. Is it gated? No, year one, it's not.
Yeah.
But we should talk about, and it would be super fun to sort of turn the microphone around, get your ideas on this. You and I have talked about this offline before. There is going to be a way to start to think about hard and soft steerage in ways that are of huge value to both the member and the plan. And I have ideas on that. We already have a sort of technical, a feature flag technical capability to do that. We haven't enabled it in production on this plan. So, I mean, your audience will understand what I mean by that. But basically, all the plumbing exists to do it. We just need
Yeah.
to sort of flip it on, and that's really a client plan design question. But let me come back to the experience because this to me is the most critical, beautiful thing, and in some ways, why while even though in 2014 I started writing about these ideas, until we had sort of really, really reliable natural language driven language models, we probably couldn't do what I'm about to tell you. So so Dot is our agent. We announced sort of what our first 18 months of Dot looked like back in the fall. We've been super pleased there. Dot in this context is doing something that it had not done before, which it greets you and says, hey Kevin, thanks for enrolling in this plan. You can even ask Dot ahead of time. You could chunk in, the three things that your kids need, the regular prescription that your wife takes, your, favorite two or three providers, whatever. You can do whatever you want. And you can sort of check the plan suitability there. That's a new idea. That's not really what we're selling on, but that all exists. The real magic actually happened once you're enrolled, where for you and every member of your household, we start to have this sort of open-ended conversational experience with you to understand where you are in your claims history, where you are in your medical goal. Now, remember who we are. In most cases, we've already been your navigation company. Even if we haven't been, we get a bunch of past claims data. So we can actually have a highly intelligent conversation with you based on where you are today. We also, because we sit on top of CLIA certified EMR that connects with the entire continent for medical care delivery and may already be your primary care or urgent care or behavioral health, we can also have a pretty focused conversation about what your exact medical history is today. So Dot's spooling these things together. We're having, this sort of open-ended natural language conversation about where you want to go. And we're constantly updating that conversation to hear what your goals are. And oftentimes we're learning things that despite all that data I just referred to, we had no idea about. You may tell us that, that you experience sort of bouts of sleeplessness based on anxiety that nobody's ever talked to you about, but you feel comfortable talking to this AI about. And by the way, that does happen a lot. People are sharing a lot more than we expected in this context. Um, Critically, what we're doing though is in that first conversation, we are starting to mirror back to you. Here's what we're hearing as your goals. So you could say, I'm looking for I'm looking for a cardiologist, or I'm looking for a new primary care doctor. I have seasonal allergies. I haven't figured it out. But anyway, we start to mirror back to you that there are topics that our primary care practice is really well trained to help you with. And we start to suggest people that we think would be really good for you that are admissible to your plan, admissible to your state, and are schedulable. And that's where sort of this like next magic step happens, where you can actually book it right through that experience. Sounds basic, but actually it's pretty cool, where you now have seen a primary care doctor that's been picked for you. This will be your primary care resource until you fire them, which you can always do. You can say, I need somebody else, or I want somebody else. But that person then acts as your primary care coach, not just against your care objectives, but also to help you understand what's on your plan, which no primary care doctor has really ever been able to do before because they weren't set up in an environment to have those conversations. So we can keep going. I want to keep going, but that's the onboarding.
Yeah.
And that's probably the part that actually, that whole thing, and I'm leaving out a lot here,
Yeah.
that was the most work. That part took more design and experimentation than anything else we do. And I should just also mention, given your audience, that's all for now. We're doing clinician in the loop on that. So we're watching 100% of those because people are saying things like, I'm having shortness of breath. I'm like whatever. So they're saying things like that you sort of have to jump in on. But But that's so far, that's the
Yeah.
conversation.
It strikes me in hearing you talk about that. I hadn't processed this before. Obviously, there's a lot of excitement around what OpenAI and others are doing in terms of
Yeah.
their tools and healthcare entry. Uh, it strikes me that a key part of y'all winning in this world is building trust with members so that they turn to you to ask those questions, to have those conversations, such that you can build up that data set profile, understand how to direct them to the right spot. I'd be curious, conversations with employers talking about trust with their employee population, where they're turning to have these conversations, what you do with that data, how you build that trust. Like how much are employers thinking about that? How much is that part of the conversation today? Or is that still moving so quickly that it's not there yet?
I think it's mostly not there yet, but I
Yeah.
suspect that it will be. Um,
Yeah.
a lot of the focus on member, consumer facing AI right now is around whether those AIs can actually treat. And so it's that whole conversation about sort of whether these are going to need to be FDA certified, whatever. In my mind, that like is sort of missing the larger point. The larger point is if you have a foundation model, and all of them are this way with the exception maybe Anthropic, but I think we should check that one long term. But if you have a foundation model is fundamentally part of an advertising business, they are really motivated to acquire just massive amounts of data about people. And, as of right now, and I've written about this, as of right now, like people are wildly telling these AIs all sorts of stuff about their symptoms and their concerns, and there is literally no legal protect. That's not a HIPAA. That's not a HIPAA protected conversation, and I don't think most people realize that. So that AI can turn around and tell anybody that information. Now, as a matter of good business practice, I'm not sure they will do that, but it's really important to understand that they can. And if they're trying to build a highly targeted advertising stream, you could see that they would sell that information to pharma, they would sell that information to insurance companies. I mean, a lot of companies would benefit from having that understanding. Um,
For sure.
Employers aren't asking that question yet, but I'm trying to go directly to consumers and be like, you should be super careful about that. And there's still very limited control about erasing that personal context even once you've shared it. So this is unfortunately not like you could sort of like have a profile and for as long as you're using that service, it's there, but then you delete it later. It doesn't work like that.
Yeah.
So that's a real concern for me.
Yeah. Makes total sense. So one part of the model seems to be building a relationship with employee, getting that data in, understanding them, building that profile. Then the second step seems like directing them to the right care, right point in time, right provider. I'd be curious. It doesn't seem like I imagine you're not building your own provider network from the ground up, papering that, et cetera. I imagine you're writing somebody else's network for that PPO product offering. How do you think about what's the data that you're laying on top of the network to understand right provider, how you're determining that? Is it quality? Is it things on top of that? Because one of the things that always struck me as hard with these models is like, okay, you go contract with the health system isn't going to want you to steer away from them. They're going to want you to send to their groups. They're not going to want you to pick docs within their groups of person A in the cardiology group at hospital X is good, person B is bad, therefore some person A, not person B. Like how do you navigate that data set and who you're sending people to?
Yeah, so you are correct to assume that, as of this date, January 30th, 2026, we're not doing any direct contracting and that the network that is backstopping this whole experience is a wonderfully deep, well negotiated, broad national network. Um, but there's a part that you're skipping over that I think is actually useful to talk about, which is just because you have one sort of base PPO doesn't mean that you can't actually build a whole bunch of switching networks on top of that that provide sort of high value for specific things. Obviously, you could think about a COE network or a fertility network being one very clear and easy example of that. Um, but other examples, might include ways to get access to, really high quality, low cost services that are separately contracted outside of the medical plan. And then you can just sort of like build that in. Um, I think sort of speaking from a technologist perspective, I think part of what's been missing is the technical ability to actually support that switching network concept.
Hmm.
And you need to have like as long as you're doing like a flat provider directory, like go in, pick, orthopedist in, San Francisco, and then that you see it, that's obviously not going to support what I'm talking about. But if the search and browse experience is actually this natural language experience, but on the back end, we have these network, high value networks that we can access and reach and pull inventory from, like that just
Yep.
starts to open up a very different idea of a network. You could even have, we haven't done this, but you could have a reference-based pricing network that is sort of accessible on the back end of that too. So we're really excited about the innovation in the network design space. Like we've been meeting with the direct contracting companies. We obviously have terrific partners in the large carriers who have built these things very carefully over periods of time. That is not going to be the area that we are going to drive the most near-term value and innovation from, but we think that there are amazing partners out there for it.
Yep. That makes sense. I So other going back upstream from the last two questions, um, go to market strategy here. One of the things that seems different about moving from navigation to selling the plan is are you disintermediating the broker relationship? Who you've been selling to in the past? Is there conflict there? How have you thought about that conversation? How does it change go to market strategy and the conversations you're having as you work with employers more directly as a plan?
I don't think so. I
You
actually
don't think
think,
so?
I just did a sort of big group meeting with a bunch of those folks the other day. And I actually think if anything, there's a ton more business in this world for them when
Hmm.
companies like mine introduce these alternatives. And so I'm really excited about that. And if you happen to be a forward-looking broker or consultant listening to this and you want to talk to me about it, I'd love to do it. But if you think about their world, they're getting a lot of that pressure we were talking about at the top around costs, around access, around sort of outcomes. And the thing that they always have access to do is a medical RFP. But you can do that over and over again, and if you don't see any differences, then it becomes an issue. Here, you could bring in another solution, and you can even partner with that solution on bringing in those network concepts that I just talked about. Like, so from a broker consultant perspective, you can stack a bunch of business. You've got the medical RFP, but you also have the network curation, assessment, refinement, and
Interesting.
selection. That's a whole other piece
Yeah.
of it.
Yeah. So it's almost like, as I process what I hear you saying, I if you're an employer, getting more and more into the complicated nature of how you offer these plans and whatnot doesn't seem like the answer for employers who have small HR teams and can't handle all that complexity. The To manage cost, access, quality effectively, you're going to move towards more complicated plan offerings where you're slicing populations in different
No
ways for
doubt.
their needs. And in that world, the broker actually plays a more important role in navigating all of that stuff and being the orchestrator of, okay, it's included for this slice and it's this model for that
Yeah.
slice and how it all works together.
Yeah,
Interesting.
you got it. You got it. And I think that and I think we're gonna see a lot of flowers blooming in the garden on this. Like,
Mhm.
real long-term competitive advantage is going to be about the ability to drive, high clinical value within a population. It's going to be about the ability to create sort of this interesting network switching concept I've been talking about and allow that to take total cost of care sort of upside
Yeah.
downside on these deals. So that's where it ultimately goes. But I think in the short term, a lot of companies can and should experiment with going to with these alternatives to employers because I think they're really listening.
It seems like they're taking off, right? Like I was reading a Willis Towers Watson article from earlier in 2025, getting ready for this, and they're talking about employers 42% of employers are offering alternative plan designs today. That's going up to 87% or something like that in a couple years. It seems like this market is um, destined to grow as employers are grappling with these cost increases, right?
I totally agree. And I
Yeah.
think a lot of companies are going to naturally evolve out of their existing categories towards this, right? So, we
Yeah.
talked a little bit about our makeup as a company. Um, but I think that sort of like one place you're going to see really good strategic and positional advantage is the companies that do navigation because we already cross-cut the entire population. We've done the eligibility integration, we've done the claims integration.
Yep.
Um, but you could equally expect that, the benefits administrators who I think need to, probably come up with a couple of new ideas themselves might come in this direction as well.
Yeah. I Last been a broad topic for me, which is kind of a future of insurance in this country question. Obviously, you look at every insurance market and it's a mess right now, from ACA, Medicare, CAID, small group commercial, large group
Yeah, there's like
commercial.
very few bright
There-
spots.
There's not much to hang our hat on
Specialty
doing well
pharma.
right now. Yeah, I we could get outside of insurance profit pools to some others that are doing
Yeah.
very well. But I it actually feels, as I hear you talking, the public markets have turned away from employer-focused digital health solutions over the last few years, right? There's been issues with revenue concentration with a big customer. That customer switches vendors, moves on.
Yeah,
It's an
right.
issue for a stock price, so on and so forth, right? Um, where do you see this market going over the coming years? Like I hear signs of hope, glimmers of optimism in this narrative as they manage costs and there's more opportunity to work with them. But how do you see the employer market evolving in the broader insurance morass over the coming years?
Yeah, I mean, I think commercial, you know, uh, broadly as a segment of the overall insurance service market, like is awesome and totally underappreciated. And I would probably, while I agree with your general setup, I think the part you missed was I just don't think there have been enough interesting scale names, to talk about as public companies. And you now have us and a few other companies that are really sort of big private companies that are doing a lot for a lot of people and want to continue to do that and have a very strong and passionate perspective on how that should be done. Um, I think that question is like when more of those companies, what's it going to take for more of those companies to sort of come into that broader capital markets frame so that we can actually talk about where the commercial market's going overall. The fundamentals of the commercial market, Kevin, are just better. I kept thinking Medicare Advantage was going to come racing back either next year or possibly the year following. I'm not sure. I mean, the more I understand about sort of what's happening there, and it's not our core market, the more I think that business is actually going to be more and more challenging over those next couple of years. Cade, same problem, right? You can
For sure.
imagine if, we already have an administration that's not particularly friendly to it, but also you could imagine if states start to see tax revenues fall with a weakening economy, Cade's
Yep.
going to be even further underinvested in. So commercial to me is not only the safe harbor, it's I think the bed for innovation. It's definitely why we as a company are like, this is where we want to spend all of our time.
Yeah.
Um, but
Totally.
overall, we got to put it together so we're really delivering results.
Yeah, it makes sense to me. I mean, I've earnings season is picking up this week. Elevance earlier on Wednesday, they lowered their overall operating margin target enterprise wide. And the reason for so doing in the health benefits side of the business, I mean, they've got health benefits, Carelon Services, Carelon RX, right? Health benefits, they dropped not because the individual business margin is dropping, but because they are seeing more mix in ACA than they expected, less in um, large group and fully insured
Yeah,
businesses. And government products have a lower margin than commercial
totally.
business, which rings very true to what you're saying there. So it is
Yeah,
going to
and
be
that
an
might
interesting
that
couple of years.
yeah, and if they're saying that, they are the sort of they are the one to watch on the
Hmm.
consumer segment on a specific basis. So, or not
Yep.
consumer, sorry, the commercial basis. So we'll see.
Yep.
I think there's so much room for innovation amongst not just those companies, because I don't think we should be relying on their innovation, but amongst this next sort of tier of companies that have enough scale to take some real bets and but still have this sort of fire and energy to do it right. So I am overall optimistic, but I don't know that we have enough public names to give a guy like you enough signal to be like, yeah, it's trending the right way.
Yeah, for sure. I mean, it's one of the challenges with public markets versus private markets right now, right? With so few companies
Totally.
backfilling public markets, there's a lack of data on what's going on in the industry, which I actually think is an
Yep.
interesting
You got it.
conversation unto itself that will be fun to keep an eye on over the coming years. Owen, I know we're getting to the end of our time. I appreciate you hopping on and chatting about all this stuff. It's been helpful in processing how the model fits in and where y'all headed and where you see the puck going. Any parting thoughts from you, things you want to share with the community, waste track progress, jobs, et cetera, that you want to plug?
Yeah. Well, great conversation as always. Sort of knew it would be like, I'm rounding out my week, and I knew I would actually have like an interesting conversation that kept me engaged. So thanks for delivering that. Um, Yes, we are hiring a ton in included health, and we've got a bunch of like technology roles. So if you're interested in building the future of this sort of insurance and value stack that we've talked about, that's one area to look. But we also have a lot of strategy roles, and I think we're really eager to meet people who want to come and be part of a team that's taking this stuff on. So I will definitely plug the job work. I'd love to come back and tell you how things do not only on the next year's enrollment, but how this first cohort starts to look, as well as the other fun things we're doing in care delivery. So it'd be fun to come back and update you.
I dig it. I would look forward to that. It'd be fun to hear the progress. And um, yeah.
All right, buddy.
All right.
Thanks.
Yep. Likewise. Take care.
Take care.